So the OSHA guidelines, you guys may be familiar with the bloodborne pathogen standard or even the Needle Stick Safety Prevention Act. And a lot of that stuff is built to keep healthcare workers safe from getting exposed to bloodborne pathogens. But some of the things they say, just like you had mentioned, don't use your fingers to remove those scalpel blades. Don't use artery forceps, and I don't know how many people in America are using that, but we do use needle drivers to take those blades off. There are tools designed to take those off that'll keep you safe and keep you from getting cut.
Clock in, scrub up, and join us behind the red line. You're listening to First Case, a perioperative podcast bringing you exciting interviews, engaging discussions, and innovative solutions that are changing the way patients receive surgical care. Each episode, we talk to frontline staff, perioperative leadership, and nursing entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the back table to the boardroom, from wheels in to wheels out, we tackle the real-life issues affecting the OR. Whether you're tuning in for surgical service education or inspiration, we're glad you're here. And now, it's time to roll back and start the first case.
On today's episode, we're speaking with Kristine Little, an OR nurse from North Carolina and consultant and nurse educator for Clicksmart. And Chris, as we continue to address those important topics that we might be reminded of in our morning huddles, or we might have a full discussion about in a team meeting, sharp safety is one of those topics that comes up time and time again. But it's for good reason, isn't it?
Yes. So all my surge techs, put down your finger, get up your needle driver, and put on that 10 blade appropriately, because Kristine and I are about to get charged up.
This is a really hot topic with Chris and Kristine. They're going to get on their soapboxes, so don't go anywhere. We'll be right back with Kristine Little.
From the studios of Healthcare HQ, you're listening to First Case.
Joining us now is Kristine Little, an OR nurse from North Carolina and a consultant and nurse educator for Clicksmart. Kristine, thanks so much for joining us today.
Thank you so much for having me.
You know, Kristine, we are covering a very critical topic today, and we have tons of things to discuss. So to get us started, why don't you go ahead and just introduce yourself to our audience and maybe tell them a little bit about this topic and why it's so important to you.
So as you mentioned, my name is Kristine Little. I've actually been in healthcare for about 17 years, and I've been an OR nurse for many, many years. Right now, I'm actually serving as an educator, and I all too often see staff members that are doing certain activities, and it makes me feel a little bit cautious about what they're doing. I, for one, have experienced a sharps injury. I've seen my coworkers experience sharps injuries. So this topic is a very, very important one to me because I don't want to see anyone else get hurt, and I want to see prevention measures put into place to help everyone.
So I want to start right in because I feel you.
Chris is really excited.
I am so excited. As an educator too, just changing the culture is so important. And it starts by making it an imperative, right? Like you have to handle sharp safely from day one and there's no option, So what I want to know is why do you think there is such a prevalence of sharp injuries in the OR? Is it just because it's a part of what we do, right? Sharps are a necessity.
Well, I think there's multiple reasons for sharps injuries, and some of that I believe goes back to people feeling like they have this sense of denial, like this can never happen to me. And if it does happen to me, am I actually going to contract an illness from this? And I think that is a big part of it. Another part of it, I strongly believe, is unnecessary self-sacrifice. So somehow people feel that if they take a risk with their own safety and they're willing to risk that safety of themselves, somehow people feel that makes them a better person if they're doing it on behalf of the patient.
Okay, both of us are sitting here with our mouth open.
Never thought about that before.
Yeah, absolutely. I don't know. Can you maybe go into that a little
let's talk
bit?
about that a little more.
Yeah.
Right, right. So often patient safety takes precedence over staff safety even. They also feel the need for unnecessary self-sacrifice. Somehow, people feel that if they take a risk with their own safety for the benefit of the patient, that they will be a better person for doing that. So for an example, if a staff member is getting a case ready for a surgeon to come in and do an operation or for a patient to come back in an urgent situation, if they get some kind of sharps injury because of maybe they're complacent or they're careless or accidents just happen and they ignore that injury and they keep carrying on and setting up the case, then they have sacrificed their own well-being for the benefit of that patient. So they're more apt to be rushed and make a mistake.
Got it. Yeah. We see things on the surge tech side all the time. Like, for example, and here we go again. So applying a sterile blade to a number 3 knife handle, right? Because we haven't used it yet, instead of using a needle driver like you're supposed to, because, your gloves are sterile. Nobody's touched the patient yet. And they do that bad habit, but one habit leads to another, which leads to another. Is that another reason why you think these injuries are happening?
Absolutely. Absolutely. I also feel like there's a lot of organizational factors that go into this. Things like cost cutting measures. This was happening largely before COVID, but COVID happened and a lot of the supply demands we were suffering from a lot of the supply demands. So there may not be as many adequate resources, but organizations are starting to look at costs a little bit more. So they're less apt to implement some of those safety measures that we need, some of the safety tools that we need to implement.
Okay, so I'm just going to jump in here just because my train of thought has just gone off on a tangent. But okay, so you mentioned COVID, and of course, everything seems to hinge on COVID these days. As a side note, I was at the grocery store yesterday and didn't really need something, but immediately, like, my post-COVID fear kicked in. I'm like, well, I should probably just buy it anyway, just in case they don't have it later. And COVID's been 4 years now, and we still have these issues.
Toilet
But
paper.
you think about it. Okay, so there were people who were nursing students, surgical tech students during the pandemic that were training. Issues with training abounded in those areas, just because of lack of availability for clinicals or for other things due to the pandemic. And obviously also lack of supplies, which then makes my brain think, okay, so people coming out after the pandemic, maybe their training wasn't as in-depth, maybe it wasn't as thorough, or because they were fresh and new and we didn't have the supplies we needed, or maybe they were taught some corners that they could cut as they got through it. And so now here we are post-pandemic and habits are worse, or maybe people weren't trained properly in the first place. Have there been more sharps injuries since the pandemic than before it?
Well, I can't really speak to the rates pre-pandemic and post-pandemic. However, I can speak to what you're talking about with the training. There were a lot of educational departments who were reaching out, trying to figure out how can we get our students trained, because they didn't have the opportunity to come into that classroom and join together to get that training. So it was up to a lot of the hospitals and healthcare facilities to help bridge that gap so that we could keep our patients and our staff members and students safe in that setting.
Yeah. Well, and as somebody who had to train during the pandemic, I can tell you it is really hard to train sterile technique through a video camera.
Wow.
Yeah, that 3D perspective that you need is really hard to get through a 2D.
Through Zoom? You mean Zoom can't show you how to follow aseptic technique? No way.
Yeah. Oh, right. It was really difficult, especially when they're not in a lab situation. And so, yeah, you think that you cover all the bases. Thankfully, we were able to bring our students back in the lab before they ever touched a live patient. Praise be. But, it is scary, but also there isn't the gift of experience. So you do have that naivety where, nothing bad can ever happen because you've never seen bad happen. And those of us who have experience, we know that that's Murphy's Law getting ready to slap you in the face.
Yeah, for sure.
Yeah, absolutely. So bigger picture here, you guys all mentioned organizations. What do the guidelines say from, our big three, AST, AORN? Can you start talking a little bit about what they say? Because, they're the ones who can start that culture of, this is the right thing to do.
Right. So you bring up a really good point with the three big organizations, AST, ARN, but also OSHA. What should we consider with what OSHA's bringing to the table? So if you go and do any research in the guidelines and recommendations, you'll pretty much find the AST and ARN align pretty closely. And when we talk about sharps injuries, we're not just talking about hypodermic needle injuries. We're talking about scalpel injuries, glass injuries, drill bits, burrs, stuff like that. But some of the recommendations that align are that they want you to use that neutral zone. Use a hands-free technique when passing those instruments and those sharps back and forth between the provider and the person that's running that back table. Communicating where those sharps actually are, using mechanical safety devices. There's a number of different mechanisms that we can use to help minimize injury of staff members or even patients, if you think about it that way. One big thing that really resonates with me is using safety engineered devices. And sometimes we get confused over that terminology because it sounds like big time terminology if you're saying engineer controlled devices. But with those, they are really simple. It's those sheaths that go over your needles, your hypodermic needles. It's those surgical safety scalpels that have the sheath that goes over the blade. There's retractable needles are another one. But when it comes to using those, sometimes implementation doesn't go so well. Surgeons say, hey, I don't like that type of scalpel handle. So you've got to think about other ways to go around that and look at the recommendations for that in that regard.
Technology and also old habits, right? Surgeons trying to get them to use a neutral zone is sometimes that can be a little difficult.
Right.
Well, hold up. Let's actually go into the neutral zone just a little bit, because that's actually a good thing to bring up at this point. Kristine, what is that neutral zone?
So that neutral zone can be different depending on what your organization says. So generally speaking, a neutral zone is a safety zone where you place that sharp down. If you're the scrub member, you place that sharp down, but make sure your team's aware of what that neutral zone is. Make sure you agree on what that neutral zone is. It can be a safe place on the Mayo stand. There's a lot of different tools out there that are made just for this. But the key component is communication. Make sure that everyone's aware of what that is. Make sure everyone's aware that, hey, this is a sharp that's in this neutral zone, so be aware of it so that you don't have two people touching that sharp at the same time.
Yeah, I've seen some facilities that actually made that a part of their timeout. So, identifying where the neutral zone is for that particular case, because some cases don't have a Mayo stand. Some of our setups are different, which I thought was pretty innovative as well. I think also as far as you've said, sacrificing ourselves for the quote unquote good of the patient. I also think we're our worst critics. So when we're transitioning in a minimally invasive case and we're done, putting our trocars in, I've watched some surgical techs not put their scalpel back on the back table quick enough. Or when you're done with this loaded suture, not transitioning that from their active area to their back table and leaving it there, that's an area of risk that's not necessary. Take that sharp and put it out of your way so that you're not going to harm yourself.
Right. Always think a step ahead. I had mentioned if that technique doesn't work for you, find something that works for your organization, that your organization really approves. They can help you make these decisions for the better of the team. Even things like using your single-handed blade remover. So that's a big technique. If the surgeon doesn't want to use that safety scalpel, well, how are you going to get that blade off in a safe manner to keep from cutting yourself?
Not your finger.
Yeah, don't use your fingers. And that kind of brings me to the OSHA guidelines. So the OSHA guidelines, you guys may be familiar with the Bloodborne Pathogen Standard or even the Needle Stick Safety Prevention Act. And a lot of that stuff is built to keep healthcare workers safe from getting exposed to bloodborne pathogens. But some of the things they say, just like you had mentioned, don't use your fingers to remove those scalpel blades. Don't use artery forceps, and I don't know how many people in America are using that, but we do use needle drivers to take those blades off. There are tools designed to take those off that'll keep you safe and keep you from getting cut.
Absolutely. And I think one thing that you just mentioned that is really important when you talk about your culture of safety within your organization and having that, the buzzword when they were talking about all of our different guidelines, the interdisciplinary team, but having that interdisciplinary team that includes the voice of your surgical techs, your circulators, your infection prevention staff, all of those people, when they're looking at the guidelines and how they are going to implement a policy for sharp safety and what they are going to do for either neutral zones, or is it going to be in the timeout, all of these things, because our guidelines are just that. They give us a ton of guidelines, and then it is up to us as the leaders in our facility and as staff to implement those with what's best for our facility. But we do, I think, start with that interdisciplinary process that hears the voice of everyone and says, okay, this is what's going to work at our facility. We're going to implement it, and here's how we are going to do this moving forward. But one of the things I think that should be included in that policy and that procedure is the insistence or demand, maybe, that an injury gets reported. Because just because an injury happens does not mean that it gets reported, right, Kristine?
Absolutely. They've actually found that 50% of sharps injuries go unreported. And
whoa,
that's scary. What?
and there's a lot of reasons for that, and it may be one of the biggest reasons is self-blame. A staff member gets injured, whether it's from a glass ampule or a inject or even a scalpel blade, and they're embarrassed to report that. And that may also be due to lack of education. Maybe they just don't know the reporting process. But sometimes people feel like they're going to get in trouble, or they're going, like I'd mentioned, they're going to slow that case down, and the staff members are going to get upset because now you've got an injury and you need to swap out staff members. But it's very important to know that reporting process, and it's very important to know that it's okay. We will get through this. We just care about your safety and your patient's safety.
So one of the things I've actually seen more often, yes, I have certainly seen surgical techs and circulators, have a needle stick or an injury. I've seen several injuries actually from loading knife handles, actually. And obviously if your hand is really slashed and pouring blood, people are more likely to report that than necessarily a small poke or whatnot, like, oh, I'm fine, whatever. But actually what I have seen more for people who don't report is actually the surgeon themselves. They get stuck or something happens and they're like, and I'll see them looking at their finger. Did that get me? Did it not? I don't know. Oh no, I'm good. I'm fine. Let's keep going. And that's it. It surprises me that, and maybe it's because they think that it's going to delay the surgery if they stop and do anything, or I'm not sure, but I've more often than not seen surgeons have an injury and they just don't say anything. Have you all seen that too?
Yes, absolutely.
Yes. I've seen every person on a surgical team that's scrubbed in do that. But what blows my mind is that when in doubt, throw it out. That's one of those nursery rhymes that we say all the time. But if that needle stuck you, then that needle is contaminated. If you use that needle on that patient, you have now broken sterile technique and you have exposed that patient. At the end of the day, every single thing that we do has got to come back to, are we doing the best thing for that patient? And that's what gets me fired up every single time we have conversations like this, is that, yes, time matters and yes, supplies matter, but why aren't you doing what you would want done for your mom on that table?
And we talked about the lack of reporting being so high, like that number is astronomical, but it's really important for staff to consider what are the repercussions of not reporting stuff. So you get to this point to where you're a staff member and you feel like we need to make a change, and I want a safer environment of care for myself and my patient. So I really want my organization to implement these sharp safety devices. Well, if nobody has reported any injuries, leadership is going to look at this situation like, why do we need to purchase these sharp safety devices if we've had no injuries? Why are we going to spend this extra money on this product if we've got no reported injuries? And it may be that they've got a ton of injuries. They just don't know about it.
Yeah, that is a good point. And speaking of injuries, I think another thing besides these sharp safety devices that we can use is, double gloving. So, we have lots of ways that we can also protect ourselves if they are going to have horrible habits, because the solution to pollution is dilution, right? And these double gloves and the indicator gloves and all of these ways for us to, instead of the surgeon staring at one layer of latex trying to decide if there's a tiny minute hole or not, we have indicator gloves that can help that expedite that problem, really quickly. But there are so many bad habits that we need to correct. And the only way to do that is by not creating them in the first place. And that comes from the future of, all of our professions, and trying to drill those down. It can be quite difficult to change. And there's got to be I think a sweet approach to doing that, especially in the healthcare field.
Right.
We're creatures of habit.
Right. And prevention's key, right? If we can prevent the injuries from the beginning, that's the key to the solution and finding.
Yeah. Well, and I think that's actually going to feed into the next part of our conversation really well, because a lot of times people will change when they finally understand the severity of the risk, if they understand the why behind they need to do it. And it's not just, some decree coming down from on high, because suddenly people kind of bristle when they're just told what to do, right? But if there is an understanding of why, an understanding of the actual risk, people are more likely to change. And so if we think about the repercussions of injury, and we think about how injury can affect the provider, the patient, our organization, like there's downstream effects to all of these, right, Kristine?
Absolutely. I mean, if you think about the amount of time it can take to recover from a sharps injury, assuming it's a bad one, it may be that the provider has nerve damage, or any kind of substantial exposure to some bloodborne pathogen. Those things take months to recover from, if you can even recover from it. If you also think about the risk of contracting hepatitis B, hepatitis C, even HIV, and okay, so you get one of these illnesses. It doesn't just end there. Now you've got to think about the treatment process of that, which is intense in itself. Being out of work from that, lost income from being out of work from that can be detrimental to a family.
For sure.
Well,
and did you report that or not?
Yeah.
And are you paying for it, or is it a workers' comp injury? Like, that's significant.
Yeah. And then add on top of that, the emotional distress from it. Some people may get injured and be fine. But I know I've been injured before, and I know I was really nervous going back into that operating room and reloading a scalpel or opening that glass ampule. It does create a little bit of anxiety after that. Yeah.
And I don't think a lot of people know that you also, if you have stuck yourself with a contaminated sharp, then they also have to then go draw blood from that patient to make sure that patient doesn't have any illnesses. And I think that people who aren't in the medical field think that, we know the history of every single patient that comes on our table. We think that we know whether they have HIV or, a hepatitis, one of the hepatitis diseases, and we don't always know that, which is why we have these universal precautions. And so, there are dangers out there that we don't always know could affect us, and which is another reason why it's so important to report.
Yeah. So then let's talk about obviously, how do we prevent sharps injuries in the first place? We've already hit on the neutral zone. We've talked about some double gloving, but what else is out there for us in terms of prevention?
So, if you can find a way to eliminate unnecessary sharps devices, do that, and I know that sounds complicated in some situations, but maybe you can use skin glue for certain layers of the skin instead. Use blunt suture needles where you can use those blunt suture needles. We talked about the engineered control devices, retractable syringes. Implement anything like that you can. Single-handed scalpel blade removals. Even your sharps containers. Make sure you have a hard sharps container on your back table, and also make sure you're taking that to a hard sharps container so that you're not getting exposed. You had mentioned the PPE as well. But one of the big components I see to implement all these things is seeking administrative help. Talk to your leadership team. Make sure you know your policies, but share that information with new hires that are coming in, and be that person that wraps your arm around someone to make sure that they are going to be safe too, because your coworkers are important as well. Make sure there's good education out there, and ask for the education from your leadership team.
Very good points.
All of those things are so incredibly important. And I think consistency in doing that, every surgery, every patient, and every single employee. Also, I think making sure that the new people that come in that don't know what to do when they get a sharp, because it's scary, walking them through the process and making sure that they're not ridiculed for, reporting an injury or freaking out when they get their first one. Because as you said, like the first time that happens, because it's probably not a case of if, but when, having those mentors around you that can tell you what to do and reassure you, that you're going to be okay and we're going to walk you through that process is a big deal. Are there any final thoughts? Because good grief, as Melanie and I always say, time has flown and we could talk about this all day, but what would you like to leave our listeners as we talk about such an incredibly important issue?
So I really want to encourage everyone to take your safety, your colleagues' safety, your patient's safety very, very seriously, because one sharps injury is one too many. Push for safer workplaces. Ask yourself the questions, what can I do to take these injuries seriously? How can I promote prevention? And how can I encourage reporting in a safe, shared workplace?
Absolutely. I love that, Kristine, taking personal ownership for it and also bringing in leadership help and really making it from the top down a commitment to safety. That is fantastic. So, Kristine, thank you so much for joining us today.
Thank you. It's been a pleasure.
That was Kristine Little, an OR nurse from North Carolina and consultant and nurse educator for Clicksmart. And Chris, I have to tell a funny story on myself when we talk about double gloving and talk about latex gloves, the white gloves, and then we have the indicator gloves and they're different colors. And when I started in the OR, we had blue gloves that were the under gloves and, we had the over gloves. But I didn't take Peri-Op 101. I didn't get any orientation. I was just, hey, here's the OR. Go learn, right? And everybody kind of takes multiple things for granted and just assumes you know things. And it was probably, it was a good year or two before it dawned on me that the indicators were a different color for a reason. And that reason was so that you would know if there was a hole in your outer glove. And I just never thought about it. And so that actually does apply to this conversation because there are some things that sometimes we just haven't thought about. And sometimes there's things or we have bad habits and we don't realize how they can actually affect us or how they can affect our patients. And so I know that you are passionate about this topic, but Kristine really did help us understand the very real risk of injury that we have and that even just one exposure could cause a lifetime of lasting effects, right?
Absolutely. And I am so grateful to have this episode to make my students listen to so that they can hear other voices yell from the rooftops the things that I say to them on a daily basis.
Right.
So it's not just about protecting you, but at the end of the day, it protects your patients, it protects your family, and it's just the right thing to do. And we 100%. Need to do the right thing every time we touch a patient.
Absolutely. And we all have to take it seriously, from what we have on our Mayo to what we have on our back table to even, like Kristine said, our sharps containers in our rooms. They don't need to be looking like porcupines. Like when those things get full, they need to be emptied. So everything that we see in our ORs, in our departments, there's a reason that we have those safety guidelines in place. And when we commit to a culture of safety, we're keeping ourselves safe and we're keeping our patients safe and giving them a safe surgical experience as well. That's going to do it for today's interview. On behalf of Chris, myself, and our whole team, thanks for listening to First Case.
Thank you for listening to this week's episode of First Case. As a reminder, you can help support us by subscribing to First Case on your favorite podcast app or by downloading the smartphone app on iPhone or Android. Simply search for First Case in the App Store or Google Play. The best thing about downloading the smartphone app is that you can access bonus content for certain episodes and view episodes in certain categories, like articles on the go and vendor spotlights. Are you following us on LinkedIn or Facebook yet? If you are and you love an episode or post, then let your social network know about it. Like, comment, or share our posts along with your thoughts and keep the conversation going. If you have any topics or guests that you would like to recommend for a future episode, just send us an email to info@firstcasemedia.com. We look forward to hearing from you.